Hey guys, my name is Tiffany and this is the last episode of Tiny Talks with Tiff, which is this little mini series that I decided to make to kind of answer some common questions that it gets asked in the NICU. 'Cause anywhere you feels right, anywhere you feels like Paris in the rain, Paris in the rain. So in this episode, I'm going to be talking about a commonly asked question that I get asked by NICU parents all the time is, when will my baby be off of oxygen? So guys, I get asked this all the time, and any NICU parents that are watching out there that has their baby on oxygen, hopefully this video is a little bit helpful for you guys to see an expected time frame that us as NICU nurses and as providers as well on what we expect your baby to be doing and the progression of the oxygen that we give them until we can finally take them off. So this is usually where we start, and this is our timeline. So if your baby is intubated and the patient you're taking care of is intubated, typically they are on either a ventilator, an oscillator, a jet, which are types of oxygen machines that we give a lot of high volumes of oxygen. So that's like the easiest way I can explain it. And then typically at this point they have a tube in their mouth, so they are intubated, and we're giving high volumes of oxygen to them. And so that is usually sometimes where we initially start off with, okay? And then the progression downward to that is after they are extubated, which is where we take out the tube, the breathing tube. A lot of times what we do is we give them non-invasive oxygen, where it basically means there is no longer a tube, but we are still giving them a source of oxygen, whether it be through a mask that we put on their nose or prongs, which is kind of like a little cannula that we put in their nose, but it still gives very high levels of pressured oxygen into their system. So a lot of times when these patients are on non-invasive oxygen, they do end up getting a lot of air into their bellies just because it is pushing up a lot of air. The machine is giving the necessary support that it needs to give to the patient. So what could happen is that they are pushing a lot of air into the baby. And with the invasive machine where they are intubated, a lot of times the baby is not really breathing on their own, and so the machine is doing it for them. Versus a non-invasive machine, typically what we can do is we put certain settings in the machine where hopefully the baby is still triggering their own breaths, and the machine kind of adjusts to that as well. So if a baby's breathing, then of course the machine won't breathe for them. But if it's not breathing, then the machine will give the breaths that the baby needs. So it still requires the baby a little bit to be able to breathe on their own a little bit. And so that is a non-invasive type of oxygen that we can give. So non-invasive types that we give are CPAP. NIPPV is non-invasive positive pressure, which is a type of setting we can do on the CPAP machine. And sometimes we may rarely, but some hospitals may do what's called CPAP as well, as another type of CPAP oxygen that we can give. And so these do push a lot of air into the baby, but they still give the necessary support that the baby needs if the baby is not breathing on their own. Once the baby gets past that stage, they move on to the next stage, which is bubble CPAP. It's still a type of CPAP, but it really does require the baby to breathe really independently on their own at this point. It still is able to open the airways of the baby and really give it the pressure and the support that it needs to keep the airways open, so that the airways do not collapse. But it does require the baby to really be independent on breathing on their own, versus the non-invasive still gives the support. If the baby does not breathe, it will still give it the support. But in a bubble CPAP machine, the baby's breathing on their own at this point, and they are the ones that are really in control of the breathing, and the machine just gives it the necessary support for keeping the airways open, but the baby is really independent. So that is the next step. And so typically we may start off on like a CPAP of 7 or 8 as the highest we could possibly go, and then we hopefully drop it down to like CPAP of 5, CPAP of 4, until we move on to the next step, which is high flow nasal cannula. So the high flow nasal cannula is the most comfortable one. The bubble CPAP still is a little bit uncomfortable because it still requires them to have a mask on their face, or even the prongs, which goes up in their nose, and it's not really that comfortable. Think of an adult CPAP machine if you've ever seen one before. It's kind of like that for babies, so it's not that comfortable. But also with with that, it's still providing the necessary pressure, like I mentioned. But with the high flow, it's really the baby is breathing on their own. It just gives them the flow that they need. And typically we may start off with high flow of 6. It's typically the highest. Sometimes we do go up to 7 or 8, but very rarely do we do. We usually start off with high flow of 6, and then we go down to high flow of 5, 4, 3, 2, 1, and then they are on room air. No more oxygen anymore. So hopefully that makes sense for you to kind of see that progression of how we start off from like a very invasive machine with a breathing tube all the way down to a cannula, which is less invasive, much more comfortable, to room air, and the baby can be off of oxygen. So just depending on where your baby is at in their oxygen level support, that's typically these standards that we see in order to progress downward in their oxygen support. So hopefully that makes sense. For all you NICU parents out there that are kind of wondering what a timeline would look like, it's kind of, that is the progression we look at. There's no specific date on the baby needs to be on this oxygen for like X amount of days. It's not that. It's just really how well they tolerate being on that support. We look at it through blood gases. So we monitor our baby's blood gases, and those numbers that we see in the blood gas really indicates to us whether or not the baby tolerates the oxygen. And if they do well and they're on very low settings on their oxygen machines, then we can start weaning them lower. So there's really no timeline on like X amount of days baby is on this type of invasive support versus X amount of days on this. It's nothing like that. It's more of just how well the baby is doing, how they're tolerating it. We look at the blood gases typically every day, every few days, to really see if they're doing well and progressing well. And if their blood gases are stable, then we may start weaning them downward. And that's just how we do it. So hopefully this video is helpful for you guys to kind of understand the progression and the timeline of babies on oxygen. And I will see you guys in the next season of the series. This is our mini series. So I'm just going to be doing 3 episodes for this series. Hopefully this was helpful, and I'll see you guys next time. Bye. 'Cause anywhere you feels right, anywhere you feels like Paris in the rain, Paris in the rain.